In a world of healthcare, where compassion is paramount, there exists a place that goes beyond the ordinary. It's not just about responding swiftly in times of crisis, it's about being a beacon of hope during life's most challenging moments. It's not just about treating an illness, it's about engaging your child's imagination and turning their visit into a memorable adventure. It's not just about a diagnosis. We make it our mission to ensure that you fully understand your condition while going out of our way to simplify medical jargon. It's not just about serving meals, it's about nourishing your body and soul with delicious and nutritious food tailored to your dietary needs. It's not just about maintaining cleanliness, it's about a pristine and hygienic space that promotes healing and well-being. It's not just about performing a surgical procedure, it's about meticulous planning and executing each step with precision and expertise. Our team of doctors, nurses, and support staff work in harmony, driven by the belief that exceptional healthcare is a combination of expertise and heartfelt compassion. Welcome to Clinics, where health and care meet.
Indeed, welcome to Clinics Health Group, where health and care meet. My name is Raymond Bila, but for Clinics Health Group's Group Medical Officer, and we are glad to welcome you once more to our weekly webinars where we host a variety of speakers from different fields within the healthcare industry, whether researchers, top clinicians, or academics, or people who are in the administrative environment in managing healthcare delivery in our country. And we are glad that this evening, in the last 2 weeks, last week and today and next week, we're exploring this new model of healthcare delivery, the funding model for healthcare delivery in our country, which is being managed or processed through Parliament and also the presidents and the National Council of Provinces went to Parliament. But we thought that we should help prepare the practitioners for the advent of NHI in South Africa. So we have partnered together with Healthmetrics and BHF, Board of Healthcare Funders and Clinics, to bring you this series. This is the second part two, the third part series of our presentations. And just note that these webinars are CPD accredited, and we are live on YouTube. So please make sure that when you register, you give us your full details as to your profession, your registration number, your email address, and your cell phone number. You don't need to post your details on the WhatsApp chat. This is only for discussions and questions. Because once you are here, it means that you've registered and we have your details and we upload them to the relevant health regulator, especially the HPCSA, those of you who are with the HPCSA. And as I said, that we are partnered with Healthmetrics, BHF and Clinics, as we are. And so I'm going to ask Dr. Pino Mavengera, who's the Managing Director of Healthmetrics, who's put together this series with us, with BHF, to do the short introduction of what he does and also introduce our guest speaker who will be talking to us this evening. Thanks, Pino.
Thank you very much, very much appreciated. And good evening, everyone. Thank you so much for coming for this presentation today. We know last week we had a good time. We really had very fundamental issues covered. Dr. Rajesh Patel helped us to go through an extensive analysis done by BHF to show the implications of the NHI bill especially. Remember, there's the policy and the bill to healthcare professionals, but also the private sector in general. So really appreciate that and would like to thank BHF for that. But it's a deeper issue, isn't it? It is about legality, right? It's about the bill. It's about the NHI is a bill, it's a law. So we thought it very necessary for us to have a legal mind, a legal look at what's going on. So we really would like to thank our guest today, Dr. Debbie Pearman, who has agreed to come on very short notice. So really appreciate that very much. But just a bit of a brief of who Debbie is. She has 25 years of experience as a legal advisor in South Africa, health sector, as you will see from almost all sectors, from both public and private. And she has also been employed a medical scheme administrator, the Hospital Association, that's a service provider, the Board of Healthcare Funders, that's funding, and also the National Department of Health, which is on the government side. So she's really well-rounded in a viewpoint of what goes on. She holds a BAL from VETS and an LLD from the University of Pretoria. And she has authored 2 legal textbooks, one on law of medical schemes in South Africa, the other together with Prof. Peter Carsten's called Foundation Principles of African Medical Law. So she really is the right person for her to talk to us. In addition to her employment, she also has served with the ministerial appointment for the Council for Medical Schemes, Medicines Pricing Committee, Ministerial Advisory Committee at NHI at various times in the past, and also has been working as an independent legal consultant for the last 9 years. I'm sure you agree with me that really she's the best person to advise us or to give us some insights into the legal implications of NHI for the private sector, especially healthcare professionals. Maybe please help us.
Thank you, Pinyo. I'm going to share my screen. Okay, can everyone see?
Yes, Doctor.
Yeah, so we can see it, yeah.
Okay. So today we're looking at the legal implications and considerations of NHI for healthcare professionals specifically. But I have to, in order to, for you to understand that better, I'm going to give you a brief introduction to the legal framework of the NHI. At this stage, the legal framework consists only of a bill, which is currently going through Parliament. It's at the point where it needs to be approved by the National Council of Provinces. So, and after that, if it's approved by the National Council of Provinces, then it will go to the President for assent, and he signs it into law. But that doesn't mean it becomes operational yet. The President will usually issue a proclamation determining the date when the different sections come into effect, depending on the readiness of the National Department of Health and also the other structures that need to be set up in terms of the bill. So that's just a little bit of background. So according to Section 3 of the bill, the Act, in other words, the bill at this stage, but it will be an Act, applies to all health establishments except the military health establishments. And it says, if any conflict relating to the matters dealt with in this Act arises between this Act and the provisions of any other law except the Constitution and the Public Finance Management Act, or any act expressly amending this Act, the provisions of this Act prevail. So it's a very important piece of legislation that basically is only the Public Finance Management Act and the Constitution could contradict it safely. So the Act is intended to be overriding legislation, but they also say in the bill that the Act does not in any way amend, change, or affect the funding and functions of any organs of state in respect of healthcare services until legislation contemplated in Section 77 and 214, read with Section 227 of the Constitution, and any other relevant legislation have been enacted or amended. So the bill is part of a system of legislation that is eventually going to have to be amended or enacted from scratch in order to implement this whole NHI system. So this bill is setting up the NHI fund, and it's setting up structures that are necessary to implement NHI, but there's other legislation, which I will mention in a bit, that will also have to be considered and possibly amended. So the fund is exempt from the Competition Act, so the NHI fund, but it's worth noting that private providers are not, and public providers are not, because the Competition Act applies to both the public and the private sector. So they are in the bill, the fund is exempt, but not anyone the fund will be contracting with. So basically, the National Health Insurance Bill establishes the NHI fund, as I said, and its role and its powers. It sets up the board of the fund and sets out its functions and how it is appointed. It establishes various committees, which are actually very important in fleshing out the bill, because the bill itself is like a skeleton. It's got the structure, but in order to see what the final product will look like, there's still a lot of regulations and things that are necessary. So there's still a lot of uncertainty around how NHI will look because the bill only is the skeleton. So it also makes mention of a health technology assessment agency. It provides for registration of beneficiaries by certain healthcare providers. So in the bill, a beneficiary of the fund, a person who wants to claim the benefits to which they are entitled under the fund, would have to register with a healthcare provider. I think that the bill uses the word accredited healthcare provider. So we don't know yet which providers will be accredited to register people with the fund. It's very public sector thinking in that sense, because I think that the thinking is that people will register, they're used to thinking in terms of public hospitals, and people often go to public hospitals for all kinds of healthcare. But we don't know if there will be private health establishments that are also accredited to register beneficiaries. So that's one of the details that's missing. It also sets out the role of the minister and the National Department of Health and medical schemes, and sets up these district health management offices, which is it's a new structure. They will be extensions. They're national health structures. They're not provincial health structures, despite their name. And then there's also provision for contracting units for primary health care. So I'm just giving you a list here of the kind of things that are in the bill and the kind of structures that are reflected in the bill. There's also going to be a health products procurement unit. So the bill is creating a lot of these structures that are government deems necessary to implement NHI. But it requires a lot of regulations, as I said, to be made by the Minister of Health primarily. And these regulations would first have to be published for public comment before they were implemented. So there's still going to be a lot of law and detail coming out once the bill is passed that we have to look out for and comment on and make sure that we are aware of, and how it affects our interests in the healthcare sector in the various categories and roles that we play. The payment, so that some of the regulations that the NHI bill mentions is that the minister must make regulations on legal relationship between fund and categories of health establishments and healthcare service providers. So that will be important regulations for health service providers to watch out for when they are published for public comment. He will also make regulations on payment mechanisms used by the fund to procure health services. So that's another set of regulations that the healthcare providers in particular need to be aware of and look out for. It's important to mention that these regulations may not all be made all at once. They may be made in stages as the different structures in the NHI system are established. And so regulations are normally published, well, they have to typically be published in the Government Gazette. And there's usually a period of 3 months or so allowed for public comment. It can be longer. In exceptional instances, it could be shorter, but usually it's around 3 months. And then also the minister can make regulations around the budget of the fund in compliance with the Public Finance Management Act. So he has to take into account the Public Finance Management Act. And the Public Finance Management Act is a very important piece of legislation that deals with the public health sector primarily, in that it sets up the duties, for instance, of accounting officers, and it has certain provisions around how various organs of state and government departments must conduct themselves with regard to finances and management of money. I'm not going to go into it in any detail here. Then also the minister can make regulations about information to be provided to the fund by health establishments and providers. So that's another heads up, in the sense that there may be information that is required of providers by the NHI fund regulations or the NHI regulations that are over and above what you typically would submit as a provider to a medical scheme if you're a private provider. These regulations could be also applicable to public healthcare providers. So you mustn't see it only as governing the private sector exclusively. Then the minister can also make regulations on clinical information and diagnostic procedure codes to be used by health service providers. Where you see HSP, that stands for health service provider. So that in itself is going to be a complex issue, because at the moment I don't know if healthcare providers in the public sector even use diagnostic procedures and clinical, the clinical codes and things like that, ICD-10 and what have you. Then also the minister can make regulations on accreditation and conditional accreditation of health service providers. Don't forget, public health service providers are also going to have to be accredited. It's not only private health providers. And then reporting to the fund by health service providers in respect of health services purchased by the fund. So you can see that there's going to be a lot of complex regulations that will still come out, that we're going to have to watch out for and be aware of and comment on. And it is our responsibility as citizens who are affected by the regulations to give reasoned and informative input, and to consider how what impact the regulations would have on our particular area of operation. So other laws that are contemplated in the National Health Insurance Bill that will be amended when it comes into operation, there's a list in the schedule of the bill. So in the bill, at the back of the bill, there's a schedule that contains a list of these other laws that are listed here and how they will be amended when the president brings the schedule into operation. So you can see there's quite a number of them: the Allied Health Professions Act, the Compensation for Occupational Injuries and Diseases Act, the Road Accident Fund Act, the Competition Act, the Correctional Services Act, Medical Schemes Act, the National Health Act, and the Prevention of and Treatment for Substance Abuse Act. So like I said, this is a very much a systemic thing from a legal perspective. It's a legal framework that has to be put into place for NHI to work properly. And then in the transitional provisions of the NHI bill, which is section 57, other legislative reforms are also mentioned. And these are not, I must stress that the schedule of the bill is as much law as the body of the bill once the president assents to the bill. So don't think that the schedule is just an attachment that's there for information. Similarly, section 57 of the bill itself sets out this calendar, if you like, or project plan or whatever. And it says that between 2023 and 2026, which is phase 1, there will also be changes that are potentially made to the Medicines and Related Substances Act, the Health Professions Act, which will obviously affect all of you. The Mental Health Care Act, which will affect some of you. The Nursing Act, which will also affect a lot of you. The Medical Schemes Act, and now we don't know if that's in addition to what is already in the schedule, or whether that will be, if only the amendments in the schedule will be made. The National Health Act, the Traditional Health Practitioners Act, and other relevant acts. So what the law is saying, what the bill is saying, is that this list that it gives in this section 57 is not exhaustive. They'll be looking at all legislation to make sure that it's consistent with the NHI system. Then we mustn't forget that in order for national health insurance to be implemented, there has to be a money bill. And that is not the responsibility of the Minister of Health. That's the responsibility of the Minister of Finance. The Constitution says that only the Minister of Finance can present a money bill. So we don't know if this bill has yet been drafted by National Treasury, but we haven't seen anything. If they have drafted something, it's still internal. The money bill will basically determine how the NHI will be financed. It determines how funding will be allocated, but it's very strictly limited to financial issues. That's why it's called a money bill. And in the Constitution, which is in section 77, it says a money bill appropriates money. It imposes national taxes and levies and duties or surcharges. So it's only about money. But it has to go through Parliament in accordance with the Constitution. So there's a process that it has to go through, and it has to be approved. And then also it will have to go to the President for assent. So it will follow a similar process to what the NHI bill is currently following, but with the proviso that it's a money bill, so it's slightly different. But all of that is contained in the Constitution. So as far as professional obligations and rights that we can see from the NHI bill as it stands currently, is that a health service provider contracted by the fund must not charge a user for services purchased by the fund. So the bill provides that healthcare services that are covered by the fund will be free at the point of service. So that means that I'm not saying NHI is free. Everyone is going to pay for NHI, but it will not be at the point of service where it will be, where the payment will be made. And also, a health service provider can charge for services that are not purchased by the fund. So we don't know what the benefit package for the fund is going to look like at this point, because the bill doesn't say anything about that. But it doesn't mean that if there's there's certain healthcare services that are not covered by the fund, that you won't be able to still offer those services and charge for them. So that's just something to bear in mind. Also, the bill says a user can pay out of pocket or through a medical scheme for services not covered by the fund, or through international travel insurance. So, if you're going overseas, normally you have to take out international travel insurance, and the same thing applies to people coming to South Africa. So the international travel insurance would usually refer to tourists that are coming to South Africa from other countries. So there's various mechanisms through which a person can still pay for healthcare services, but only those not covered by the fund. But now you have to also bear in mind that there are certain conditions upon which the fund will cover healthcare services, which we'll get to a little bit later. But just briefly, if a user doesn't follow a referral pathway, or if the Benefits Advisory Committee doesn't think that a health care service is medically necessary, or the doctor contracted to the NHI fund doesn't think it's medically necessary, then the fund won't pay for it. But then if the user wants to continue to get those services, then obviously the user can pay out of pocket or through a medical scheme. But the other thing to also remember is that if a user does not want to go to a particular hospital that's contracted with the NHI, but wants to go to a different hospital that's not contracted to the NHI, or a healthcare provider, the fund doesn't cover those services either. So then that person will have to pay out of pocket or through a medical scheme. So there are complexities to this. I'm stating it at a very simple principled level at this point, just telling you what's in the bill itself. But how these things actually work out in practice is going to be quite a complex affair. So I've already mentioned that users will have to register with the fund at an accredited health service provider or health establishment, but we don't know what the plans are for that accreditation, whether it means simply an accredited health service provider or health establishment that has been accredited by the fund, or whether it's just, in other words, anyone who's contracted or accredited to the fund or by the fund can register users, or whether it will have to be a special accreditation to register users. I suspect the latter, but we'll see what happens, because don't forget, the National Council of Provinces can also potentially make changes to the bill as it stands now. So that's just something to bear in mind, is that what the bill that we saw the last time that was published for public comment, or that was published once Parliament, National Assembly passed it, may not necessarily be the bill that we see at the end, which the President has signed. So I just want to make that point clear. So basically a user, and a user means a person who's going to benefit from the NHI fund, will have to present certain documents to a provider in order to register. So for example, an ID card, the bill specifically refers to an ID card, not an ID book, but yeah, I won't get into that. Or an original birth certificate, note, not an abridged birth certificate, but an original one, or a refugee ID card, because refugees will also be covered by the NHI fund. So this could mean more administrative work for providers of healthcare services if they are required to register users. The idea is that if you want to, if you go to a provider and you want to select a provider as a patient, so in other words, as a user, you want to choose, let's say, which GP you want to go to for NHI benefits, for NHI covered services, then that's the provider that you would register with. But there's still, as I said, a lot of uncertainty, and we're only seeing the bare bones now. So there may be regulations, in fact, there probably will, I've mentioned them before, that will come out that will be more detailed and more specific about how this will work. The other thing is that providers will have to contract with the fund and follow referral pathways to get paid. So if you have a contract with the fund, but you don't follow referral pathways, you won't necessarily get paid. But also, there's no guarantee that the fund will contract with private providers. The government has said that it wants to contract with private providers, but what I'm trying to tell you is that a contract is a two-way street, and both parties have to agree. Nobody can force you into a contract, not lawfully anyway. They can try and apply all kinds of pressure and offer you all kinds of carrots and what have you, but a contract is a voluntary process. So, and in fact, in the NHI bill, it says that the NHI fund will contract selectively with private providers. So it's not necessarily going to contract with everybody either. So they've already anticipated that in the bill. Providers can choose whether or not to contract with the fund. I've made that point. The registration with a particular provider restricts patients from using other providers. So in other words, patients will have to choose whether they want to see a provider nearer to their home, perhaps, or nearer to their work, depending on what their personal circumstances are. They will have to decide which provider they're going to register with, because registration, direct registration with a fund at this stage isn't contemplated in the law. So you can't go to the fund itself or go online to an NHI fund website and register there. The way the bill is written, it contemplates that users will register with providers. We also don't know if users will register, because it's not a crime if you don't register. So there's all these uncertainties and unknowables that will only become apparent as the whole thing unfolds. But the bill does say the minister must make regulations on portability of health services. So in other words, when the user is allowed to use another health service provider. So if you go on holiday, for instance, and you're far from where you live, then and someone gets sick, obviously you can't go to that health service provider, the one that you registered with or the one that you selected as your main provider. So the minister is going to have to make regulations on how people can get benefits from the fund, even if they use a different health service provider. But I must stress that people will only be able to use those that are contracted to the fund, if they want the fund to pay for the healthcare. So if the health service provider is unable to provide the necessary healthcare services, so let's say a patient registers with you, a user registers with you, but for some reason they have a health condition that is outside of your scope of experience or skill or whatever, or that they need the services of some specialist or something, then there's a responsibility to transfer the user to another health service provider. So that's, again, public sector thinking, because normally patients are transferred, literally, they transported to the other health service provider. But obviously, if we're talking private GPs and other kinds of private health care service providers, they don't transfer, they can refer, but the word used is transfer to another health service provider. So yeah, that also becomes a bit of a point for discussion, but hopefully it will be clarified in the regulations, because there is provision there for regulations to be made in that regard. So the fund can refuse to pay if no medical necessity exists or no cost-effective interventions exist. So cost-effective is a subjective term, and that will have to be determined by a health technology assessment or the formulary, because the NHI bill provides for a formulary of medicines that the NHI fund will pay for. So the NHI fund can refuse to pay for a medicine that is not on the formulary, and it also can refuse to pay if there might be a treatment out there, but if it's not deemed cost effective, then they won't pay for it. Then we continue with professional obligations and rights. The fund must negotiate the lowest possible price for goods and health services without compromising the interests of users or violating the law. So the fund must negotiate, but we don't have any indication of what the negotiation mechanisms will be from the bill itself. So this is likely, again, to be covered possibly by regulations. And providers will still have to be careful of the Competition Act, because as I said in the beginning of my presentation, the fund is exempt from the Competition Act, but not providers. So the Competition Act currently, according to the Competition Commission, does not allow collective bargaining on the side of those that it applies to. So in other words, you wouldn't necessarily be able to have a whole bunch of healthcare providers coming together to bargain with the fund. at the same time, it's insane that the fund would have to sit and bargain with every single individual provider. So that's still an unknown that we have to see what comes out of regulations and other things like that. The Benefits Advisory Committee will determine and review treatment guidelines and benefits payable by the fund, including the types of services. So as I said in the beginning, the work of the Benefits Advisory Committee will be very important in determining, for instance, what medical schemes can pay for and what they won't pay for or can't pay for. The treatment guidelines to be used in treating NHI users. So the treatment guidelines will be standardized across the NHI fund beneficiaries. So that may impact health professionals, especially in the private sector, who use different kinds of treatments or different approaches, not necessarily wrong, but just slight departures from so-called standards or whatever. So that is also something that will have to be very closely looked at by individual providers once we see what the Benefits Advisory Committee puts out. Providers contracting with the fund will have to comply with these treatment guidelines, and it's likely to be based on current public sector guidelines, but of course those can change. We don't know, we can't predict in advance what the Benefits Advisory Committee is going to come up with. Health service providers must comply with the provisions of the National Health Act relating to access to health records and protection of health records. That's a provision in the NHI bill that's completely unnecessary, because you don't write law that says you must comply with the law. I mean, that you don't have to prop up the National Health Act with the National Health Insurance Bill. But anyway. So then there's these contracting units for primary health care, which I mentioned earlier, and they consist inter alia of private providers organized in horizontal networks within a specified geographical sub-district area. So I don't know what that means. I don't know what horizontal networks are. A specified geographical sub-district area is easier to come to grips with, because that seems fairly obvious. But remember, it consists of private providers, but also potentially public providers as well, like district hospitals and that kind of thing. And this contracting unit for primary health care, so it's primary health care only, bear in mind, must manage contracts with accredited health service providers in the prescribed manner and subject to prescribed conditions. So that the word prescribed means regulations have to be made. So that is another thing that is unknown to us at this stage. Funds for primary healthcare services must be reimbursed directly to accredited and contracted primary health service providers and health establishments at the sub-district level. So that is a provision in the bill itself, in the Act. Bear in mind the regulations can't contradict the Act. Regulations are subordinate legislation, that's what we call them. So they have to be consistent with the Act that Parliament passes. So, yeah, it's not actually clear what reimbursed means. I don't know if reimbursed means the same as paid. I'm a lawyer, so words matter and these distinctions matter. But it seems that there's a sort of a subsystem that will be in place specifically for primary healthcare as opposed to other kinds of healthcare. And then the bill says mobile emergency medical services must be provided by accredited and contracted public and private health service providers on a capped case-based fee basis. So we also don't know what that means really at this point. It sounds like it's maybe a kind of capitation fee, but it's not entirely clear that it will be a capitation fee, and it's case-based. So I don't know if they're contemplating diagnosis-related groups or what they mean there. but that's what the bill says. And I don't know also what is necessarily meant by mobile emergency medical services, because there's another provision which says that public ambulance services must be reimbursed through the provincial equitable allocation. The provincial equitable allocation simply means through the provincial budget. And that's because in terms of the Constitution, ambulance services are a responsibility of the provinces. So it's possible that mobile emergency medical service may be referring to private ambulance services and helicopter rescue services and that kind of thing. I'm not entirely clear, but at least public ambulance services will be reimbursed by the provinces pretty much as usual. And then a health service provider must procure health products according to the formulary. So normally providers in private practice don't dispense medicines. There is the exception of dispensing doctors that are authorized to dispense medicines in terms of the Medicines and Related Substances Act. So, because the word procure means to source, and to buy. It can potentially mean to buy as well. So bear in mind that health service provider could be a private clinic or a private hospital, but it also could be a dispensing doctor. And suppliers listed in the formulary must deliver directly to the health service provider. The other thing to bear in mind is that the single exit price system that is provided for in the Medicines and Related Substances Control Act will still apply in the private sector. So private providers will not be able to source medicine at public sector costs. Just something to bear in mind. The contract between the health service provider and the fund must contain a clear statement of performance expectation and need in respect of patient management, volume, quality of, and access to services. So that must be things that must be included in this contract between the health service provider and the fund. So that gives you an idea roughly of the things the contract will cover, but it doesn't actually tell you too much about what your contractual obligations will actually be. A health service provider will have to provide certain information before the fund reimburses, including patient ID, diagnostic and procedure codes, details of treatment, including medicines dispensed and equipment used, diagnostic tests ordered, length of stay of an inpatient, etc. So it's not entirely clear whether all of this will apply to outpatient providers of outpatient care, or whether only length of stay is the relevant section that will apply to providers of inpatient care, because obviously it can't apply in the case of outpatient care or ambulatory care. But it's likely that providers are going to have to supply a lot of information to the fund to get paid. And it could mean that you have to keep more detailed records. The performance of a health service provider must be monitored and evaluated in accordance with the NHI bill, and appropriate sanctions, that's the words bill uses, must be applied where there is deviation from contractual obligations. Now, normally in contracts, which are remember, they're only binding between the parties to the contract, they normally would stipulate penalties, usually financial penalties. But I'm now talking just generally. I'm not saying that these would be appropriate sanctions, but if I think about normally the kinds of things that people do when other people don't deliver on what they're supposed to in terms of the contract, is that they normally agree to certain kinds of penalties. And these penalties are usually financial. But at this stage, I can't say what these appropriate sanctions will look like. The fund must review accreditation of health service providers every 5 years. So bear in mind, the fund has to accredit health service providers that in order to contract with them. But then in addition, the fund will have to review that accreditation every 5 years based on the performance of the provider and that kind of thing. The fund may withdraw or refuse accreditation if the health service provider does not comply with referral pathways, does not supply required information, cannot ensure allocation of the appropriate number and mix of healthcare professionals to deliver the health services specified in the Gazette. Don't ask me what that means in relation to individual private providers, because I can't tell you. Delivers poor quality services, fails to adhere to the national pricing regimen for services delivered, etc. So that's just to give you an idea. That's one of the provisions of the bill. I've just cited the most notable ones for your attention. Our service provider must be reimbursed in accordance with the prescribed capitation strategy. So there's more regulations for you. We don't know what will be included in the capitation strategy. In the case of specialist and hospital services, payments must be all-inclusive and based on the performance of the provider. So that's quite vague. We don't know what all-inclusive means. I don't know if it means inclusive of technology costs. It's really hard to know what is meant by that without any more information. The minister may make regulations that provide that payments to be made on condition of compliance with quality standards. So in other words, he can make a regulation that says, if you don't comply with the quality standard set by maybe the Office of Health Standards Compliance, maybe by the minister in terms of regulations under the National Health Act, maybe by the fund, then you won't get paid if you don't comply with those, wherever they are located, wherever they're stated. If you don't comply with the quality standards, you won't get paid. The minister can also make regulations that determine payment mechanisms for an individual health service provider. Yeah. I have no further comment. That is also open to interpretation as to what it means. Provide that payment is subject to conditions outlined in a contract. Well, to me, that's just ridiculous, because a contract is a legally binding document agreed to by the parties. You don't need to provide in law that payment is subject to conditions outlined in a contract, because usually the contract itself would specify that kind of thing. As far as complaints and appeals are concerned, the provider has the right to respond to a complaint against him or her. There's a complaints and appeals process provided for in the National Health Insurance Bill. And also a provider has the right to complain to the fund. So it works both ways. A provider can also appeal to the appeal tribunal against the decision of the fund. The appeal tribunal is another structure that is provided for in the bill. And the bill also makes provision for offences and administrative fines. So an offence is criminal conduct, and it's dealt with in terms of the criminal law. But an administrative fine is a fine that's levied by an administrative body when it issues a directive and somebody fails to comply with the directive. And it's usually for every day that you in violation of the directive or the rule or whatever it is, you will pay a certain amount of money. Whether that will apply to health service providers, I'm not sure at this stage, because, as I said, it's regulation. So you can see that there's so many unknowns, and we only have the skeleton at this stage, which has to be approved by Parliament and then signed by the President. And I must tell you that the President's signature is not a rubber stamp. The President himself has a constitutional obligation to make sure that the bill, he's satisfied with the bill. So a lot depends on terms of contracts with the fund, which we don't know about, regulations, which we don't know about, negotiations on price for healthcare services, which are an unknown quantity. We don't know the mechanisms for doing that. The work of the Benefits Advisory Committee and other committees with regards to the benefits offered by the fund, treatment guidelines, health technology, the formulary, etc. None of those are set out in the bill itself. And we also don't know how, what amendments will be made to other legislation. So, for instance, the Health Professions Act. The government, by the way, doesn't need permission in terms of the National Health Insurance Act to amend other statutes. The government has the power, independently of the National Health Insurance Act, to amend other laws. That's a power that's derived directly from the Constitution. But in any event, the National Health Insurance Act is giving us some idea of the other legislation that is going to be targeted for amendment. Providers will have to decide if the risks and costs of servicing NHI patients are worth it for them. So if the NHI fund offers a fee that is too low to make your business sustainable, that's something to consider. You will also have to consider how you want to structure your patients your practice, for instance, purely around NHI users, or a combination of NHI users and medical scheme patients and cash patients. What about patients who don't register for NHI? There may be people in the country who are not entitled to register for NHI, but will still need health services. But a lot will depend on where you practice, how you practice, what your, what kind of patients you get from the area. If you've got any special skills in any particular area, even if you're a GP, some GPs have little, I don't want to call them specializations, but they have certain services that they offer that they focus on. So that's all things that providers will have to consider. But as I said, at this stage, it's hard to take informed decisions because there is so little information in the bill itself. Another consideration is, will you lose patients if you don't contract with the NHI fund? So if you're servicing a lot of patients that are from the lower end of the income spectrum, the chances are that they will all be NHI beneficiaries. So that's something that you'd have to consider as well. And also then, depending on what happens with medical schemes, because the NHI bill does say that medical schemes will continue, but when NHI is fully implemented, then they will only be able to offer complementary cover. In other words, cover that isn't provided for by the NHI fund. So we don't know what's going to happen with medical schemes yet, but it's not, I'm not saying you must panic and go running around like a chicken with your head chopped off. I'm just saying these are things you need to start thinking about and looking at your practice or your clinic or whatever it is with an objective eye, and start to think about these things in the context of the National Health Insurance, and identifying what would be best for you as far as whether or not to contract with the NHI fund, all that kind of considerations. It could be more expensive for you to contract with the NHI fund than to not contract, but that would depend on your own individual practice and what patients you serve and that kind of thing. You will also have to revise your contractual relationships with current suppliers. So for instance, when the formulary comes out, or when the Benefits Advisory Committee comes out with what is covered by NHI, or when there's health technology assessments done by the Health Technology Agency, or the fund itself, I don't know. Then you would, if you have current suppliers that you deal with, you would have to revise those contractual relationships if you are going to serve NHI fund users. You would also then probably have to make sure you have enough information about other contracted health service providers in your area to make approved referrals. So you wouldn't be able to refer your patients to just anyone. So for instance, if you are a GP and it becomes apparent that your patient needs counseling from a psychologist, you would only be able to refer your patient to one that is also contracted to the NHI. As far as risk management and compliance is concerned, so I've put a but there because in the previous slide, I've said a lot still depends on all these things here. So there's a lot we don't know. But some of the things we do know is that you will have to follow NHI treatment guidelines, referral pathways, and the formulary to get paid. You will have to collect potentially more information than you do now for submission to the fund. You will be subject to closer scrutiny as to compliance with codes of ethics and the law, because the fund can terminate contracts if you don't comply with codes of ethics and the law. You will have to be extremely diligent about record keeping. You will have to have, you potentially may have more administrative work to do, and it may affect your IT systems. So that's something to think about. You will have to collect documents from patients registering with you for NHI purposes. So for instance, a patient's ID card or an unabridged, an original birth certificate. You will have to keep information about the equipment you use to render services. So I don't know at this stage what is meant by equipment. That is still something that will have to come out with further regulations and when the bill is fleshed out by regulations. You will have to jump through significant hoops to be accredited by the fund, potentially. Dr. Patel, I think, covered this in his presentation last week. You will have to strictly adhere to NHI pricing for NHI patients. You will have to use diagnostic and procedural codes determined by NHI or in terms of the NHI Act. And potentially your current costs of compliance and risk management will increase and you'll have to be more familiar with the law as it pertains to you. So depending on how well the NHI fund is implemented and how well it works, because it's all very well setting it out on paper and in law, but implementation is it's easier to write law than to implement it. So we don't know to what extent and how effectively this law will be implemented, and it's all pretty much still up in the air. There's a lot of uncertainties, but this is just what the NHI bill is telling us for. And that's the end of my presentation. Yeah, so we can have questions now.
Thanks a lot, Dr. Devi. I mean, yeah, sure. There's a lot of unknowns in what you've just presented. There are questions about the money bill. But before we go there, because the man who runs the Treasury, the Minister of Finance, if I'm not mistaken, he was quoted as having reservations about NHI himself. So if that is the case, what are the chances that he will be able to give the appropriate money bill? If you'll correct me if I'm mistaken, unless he was misquoted.
There does seem to be some tension between Treasury and the National Department of Health. It's not really very public, but for instance, Nicholas Crisp was quoted as saying that medical schemes tax credits will be withdrawn, but that's not a decision of the Department of Health or the Minister of Health. That's a decision to be taken by the Minister of Finance, because the Income Tax Act and other tax laws fall within his portfolio. So the Minister of Finance has currently been saying South Africa is in dire straits financially, and he's been wanting to introduce austerity measures, and saying that we're going to have to government is going to have to tighten its belt. So it's hard to see know how that will play out, when the bill has to be implemented. But a money bill is constitutionally necessary, and where the money will come from, the Minister of Finance knows probably better than I do. If there is money, I can't really comment on that.
Yeah, because the first question says that surely this money bill is very important, says Geraldine Bartlett, and to determine what and how much can be provided as the NHI benefit.
Yeah, no, the money bill is very important. Basically, they can't implement NHI without a money bill going through Parliament and being passed. But maybe they're waiting to finalize the NHI Act to see what then is required for the money bill, but it's difficult to say at what stage, because Treasury has been very quiet on the money bill side of things. We haven't heard anything. We haven't seen anything. Nothing's been published for public comment. So it may be coming further down the line.
Okay. Second question from Geraldine Bartlett said, did you say there will be two prices for medicines? SCP, I don't know what, for the private sector, and another price for the public sector providers?
Yeah, so what happens currently is that the prices of medicines in the private sector are governed by the medicines pricing regulations made under the Medicines and Related Substances Control Act. And the public sector is not bound by those regulations. The government goes out on tender to buy medicines for the public sector.
Mm-hmm.
But it can get those medicines for much cheaper than the private sector, because it can get volume discounts. But also the pharmaceutical industry has said that basically the private sector is making it possible to government to get those discounts. So the pharmaceutical industry doesn't want to see a situation where private providers are able to get those medicines at government cost, because then they say it won't be affordable to give government those discounts. So that's what we have currently. However, I want to draw your attention to the fact that I did say there would be potentially amendments to the Medicines and Related Substances Act. That is one of the acts that are mentioned in the bill. So that situation might change. I can't possibly say that at this stage what will happen, but the fact that amendments to the Medicines and Related Substances Act are contemplated in the National Health Insurance Bill means we might expect changes in that regard. Yeah.
And Helen Solomon, so can the provider treat both NHI and the private at the same time?
Yes, there's no restriction on the patients that a provider can treat at this point. I don't know if the contracts that the NHI fund will want to enter into with providers will try to restrict them, but if I was a provider, I would seriously not want to agree with that kind of contractual term, because it's unconstitutional, basically. Everybody has a right to healthcare, and just because you're not an NHI fund beneficiary, that doesn't mean that your right to healthcare is any less than that of a user of the NHI fund. So I doubt that they will try to put that kind of contractual term in. It's possible they will, but as I said, it's all very much in the air, because the minister has to make so many regulations that regulations could provide more clarity on that kind of thing as well.
Yeah, but it also it does look like the beneficial, the public, anyone who wants to be patient wants to get access to healthcare, you may, if you choose to be on NHI and on the private and also on medical scheme, so you'll have to be paid double. Just you'll be taxes for NHI and then out of pocket for medical scheme. Is that the case?
Are you talking now about patients specifically?
Yes, patients, yeah.
Yeah, so we don't know what the contributions to the NHI will be or how taxes will be applied. The Department of Health has said that basically the funding will come from taxes, but we don't know because Treasury has said nothing on how it will raise the money. And so the National Department of Health is technically not qualified really to comment on that in any depth. There is a provision in the bill that talks about potentially payroll tax, general, I think, income tax. So it gives a few options, but what Treasury finally puts into the money bill, and don't forget the money bill may necessitate also changes maybe to the Income Tax Act. This whole NHI thing is huge, and people don't realize just how huge it is as far as its impact is going to be on South African society and the legislative framework in general. So, but if you want to be on a medical scheme and be a beneficiary of NHI, it won't necessarily cost you double, because we don't know yet what NHI is going to cost in terms of tax implications. And we also don't know what medical schemes are going to be able to pay for. So they will obviously base contributions on what they can pay for, but what they can pay for depends on what NHI pays for. So it's all unknown at this point.
Yeah, from I would say the one, will a dispensing doctor be reimbursed for meds dispense plus the dispensing fee as well as the capitation rate for the consultation? You did mention that you, as a lawyer, you've got problems with the word reimburse. You don't know what it means. It might mean many things.
Yes. At this stage, the bill is silent. There's no mention specifically of dispensing doctors. But obviously, if the dispensing doctor is contracted to the fund, then the dispensing doctor will have to procure the same medicines that the fund pays for, but not necessarily at the same prices that the medicine is paid for by the public health sector, depending on what happens with the Medicines and Related Substances Act. So the dispensing doctor will have to use the medicines that are in the treatment guidelines and also on the formulary. And then technically he should be paid. I mean, it's not that he can't be expected to provide that out of his own pocket. So it's not that the fund won't pay for it, but there will be restrictions on how the dispensing doctor, for instance, procures the medicines. Yeah. And what treatment guidelines he follows.
Yes. And Martin, was just in tongue-in-cheek, you said there are too many levels of administration and regulation to make this a viable proposal, and says is there that is retiring. May I maybe sense a question or a feeling in that comment, maybe not spoken, but other people have said it. Will NHI destroy the healthcare system in the country?
That's a politically loaded question. There's just so many things that can happen between now and then that I can't really give an informed answer to that. There is a risk that it could destroy the healthcare system. There is a risk, but how high that risk is, how serious the risk is, I can't say, because there's so many things that are still unknown that have to be where we don't have any details. There is a serious risk. I mean, a lot of people commenting on the bill are really worried about corruption. We are sick of corruption as South Africans, and some people have said the object is it will just centralize corruption. Instead of making it at provincial health department level, it will go to NHI fund level. But those are cynical people. I mean, I try not to be too cynical, but at the same time, I'm a realist. So Yeah.
Yeah.
It has potential to destroy the health system, but it all depends how government does it. So we have to trust that government will do it responsibly, and there are provisions in the NHI bill relating to fraud and corruption and that kind of thing. But yeah, I suppose it depends how much trust you have in the government at this point.
Yeah. Well, we hope that it is going to make healthcare accessible to the majority of our population and also improve healthcare delivery both in the public and the private sector.
Yeah.
That's the purpose of, I think, NHI in terms of universal healthcare coverage.
Yes,
I don't see any further questions. I don't know if you've got any last comments from your side before we...
I just wanted to say people mustn't confuse NHI with universal health coverage. There are many different ways to achieve universal health coverage, and the World Health Organization itself has said that national health insurance is not necessarily the best solution for every country. So universal health coverage is something everyone can get behind, because nobody wants to see somebody go without health care that they desperately need just because they can't afford it out of their own pocket or whatever. But at the same time, it's important not to confuse universal health coverage with national health insurance. And the principle of national health insurance is fine, but the devil is in the detail. It's how it is implemented, how it is structured. And our government has a strong reputation for putting through legislation, but it doesn't have such a strong reputation for implementing it. And you can have the best legislation in the world. If you can't implement it properly, if you don't implement it properly, then it may as well be bad legislation. You know what I'm saying?
Yeah, definitely. Yeah. Okay, thank you, Pino. Dr. Mavengere, if you can just maybe make your last comment before we come to the close of this webinar. Pino? Are you still there, Pino? Okay, it looks like he did say to warn us that he was going to get load shedding. Yeah, I think it's just left for me to thank you a lot, Dr. David Pierre, for this wonderful presentation. Quite a number of people have been saying that they've quite an interesting presentation. I think you outlined legislation in terms of what to expect from this bill, and we are hopeful that once the president it goes to the National Council of Provinces and also the president applies his mind and he passes the bill, that when it becomes an act and there will be regulations that will answer those many unknowns that you've mentioned, that there are quite a number of unknowns, and that will be able to implement it, and hopefully that will be something that will help us with the improving healthcare delivery in our country, both in the public and in the private sector. We just want to thank BHF and Health Metrics and Clinics Health Group for putting together this series on the NHI, and we'll be concluding our series next week, and we hope to have a fruitful discussion, and thank you once more for making yourself available.
Thank you. Yes, I'm sorry about the dark, but load shedding,
Now we live in this country.
Yeah,
but also want to thank all the colleagues who've logged in. I think we've had more than 330 participants logged in for this presentation. It's quite a high number, and we are thankful to all of you for being able to log in every week. And a special welcome back to Martin Richardson. He has not been able to connect to load shedding. I think it's been difficult for him, and others who have joined us for the first time. We want to thank you very much, and we hope to connect with you again next week as we continue with our series on NHI. And to thank also Kamo Usako, we've been working together this past year and a half or two, making sure that we have these presentations and webinars streamed live on YouTube, and so we're getting speakers every week. And to thank Clinics Health Group, the executive, for allowing us to have this platform at a cost to the company. And thank you very much, and have a good evening.
Thank you. So well.
Thank you.